Yeah, so if a patient did receive second-line therapy, let's say Taxol and Cyramza, and then after some time had progression, the question begins, the question becomes, is third-line therapy an option? And I think it, again, is a discussion. I mean, it depends on the performance status. If a patient is having a lot of ascites, having visceral metastases, spending more time in bed than not in bed, then it's not clear that a third-line treatment would be very beneficial, and it may be better to think about best supportive care or hospice. If, however, the patient's quite functional, active, and is motivated to get third-line therapy, then obviously I would look for a clinical trial, but short of a trial, I would consider a third-line agent, typically irinotecan. Closing thoughts for this case. We talked about how it's unfortunately a typical presentation, and we talked a lot about the standard options for treatment. I might just mention that I think the options that we talked about in this interview are likely to change in the next 6 to 12 months. I mean, drug development in gastric and GE junction cancer is quite active. Thousands of patients are in clinical trials. We're awaiting the phase 3 data of the first-line regimen of FOLFOX plus or minus the MMP9 inhibitor and endoximab. And if that study is positive, that may change options. We're awaiting data from the first-line pembrolizumab study. The first-line nivolumab and ipilimumab phase 3 study is still accruing, but that may change options. And that's just what we know about now. We just a month ago received approval or positive data of Lonsurf from the third-line setting, so that'll change options as well. I think the shelf life for this interview is fortunately not going to be great or actually you can invite me back because there'll be other options in the not too distant future.